Thank you very much indeed, Devi. Hello and welcome everyone to Rio Rhythm Interventions Online 2024 and this live symposium on cryoablation and pulse field ablation, competing or complementary in AF management. My name is Faizel Osman and I'm an electrophysiologist and honorary professor at University Hospital Coventry here in the United Kingdom. It's my great pleasure today to welcome the three speakers we have, Dr. Neil Srinivasan, Dr. Verena Tscholl and Dr. Ioanna Koniari. Today's symposium is supported by Medtronic. I'd like to encourage all of you to actively participate, please. Share your thoughts, your insights, your questions. Use the Q&A box at the bottom. Your engagement is absolutely vital, and we look forward to addressing your comments and your questions at the end of the session when we have our panel discussion. Just a little bit of perspective about my experience here in Coventry. I was appointed in 2008 to start the EP and complex ablation service here. In 2010, we started AF ablation using the PVAC catheter from Medtronic. And within a couple of years, we had a 3D mapping system. But it was the advent of the cryoballoon in 2015 that really revolutionized the way we were treating AF ablation and tackling our huge waiting list that we had here in Coventry. And that also allowed us to develop our hub and spoke model and our same-day AF ablation services. We're also now doing Pulse Select PFA, and certainly the early experience has been very, very positive. So I'd like to hand over to our first speaker, Dr. Neil Srinivasan. He's a consultant electrophysiologist working at the Essex Cardiothoracic Centre. He's also honorary senior lecturer at the Anglia Ruskin University. He is trained in London at St. Bart's Hospital and also University of Washington, and has extensive experience of AF and VT ablation. He's done lots of cryoballoon ablations and is also now doing Pulse Select PFA. His talk is entitled The Ice Age, Exploring the Future of Cryoballoon Ablation. And I'll hand over to Neil. All yours, Neil.
So thank you very much for that lovely introduction, Professor Osman. I'm Neil Srinivasan. I'm a consultant cardiologist here at the Essex Cardiothoracic Centre. These are my disclosures, and the title of my talk is interesting because I'm sort of taking us back to the Ice Age with exploration of the cryoballoon in terms of management of atrial fibrillation in a conference that is about cutting edge and the latest technology. And I hope that by doing my talk, I'll show you all that the cryoballoon is not going to go away and still has a major important role in everything we do. These are my disclosures. And I'm going to start by just describing the sort of single-shot portfolio that Medtronic has on offer and that we use here at the Essex Cardiothoracic Centre. So you obviously have the Arctic Front Advanced Cryoballoon, which is a mature technology, and also newly Pulse Select technology for pulse field treatment. And we have been using both systems a bit like Professor Osman has in Coventry. So in terms of our practice, the cryoballoon still remains the really important workhorse tool for our treatment of atrial fibrillation. It really is our go-to and first-line therapy for all atrial fibrillation in our service. And the benefits of it really are in its generalizability here. So there's no need for a general anesthetic, which saves us in terms of anesthetic support. There's no need for resources to be used in that service in that sense, and also that it can be done under physician-led sedation, and it allows our workflow to be extremely efficient. I think most UK centres that do high volume cryo are doing somewhere between 4 and 6 cases per day. They're all day case procedures, and that's a huge saving in terms of space in a procedure that is highly predictable. In terms of the Pulse Select portfolio, we're obviously started using that, but we are in a sort of learning phase within using that. All our cases require general anesthetic, which is not widely available in the UK, and we struggle to get regular general anesthetic cases for our EP lab, and often reserve these for the more challenging cases, such as ventricular tachycardia ablation or complex atrial tachycardia. And we have been predominantly using this at the moment in terms of patients where we want to do redo procedures, or we want to do ablation beyond the pulmonary veins in the first sitting, perhaps persistent atrial fibrillation, where we may wish to do posterior wall ablation. And so what I really want to take hand over to people and get a take-home message here is that we finally invented something that works. And there really is not a huge need to reinvent the wheel. The workhorse tool still has an important role in our management. We know that the balloon and cryoablation has a strong background of evidence. We've got over 23 years of experience with it. It has formed over 2,000 publications, and we have performed over 1.4 million cases with the Medtronic cryoballoon worldwide. So it has really been pivotal in forming the evidence for our treatment for atrial fibrillation, particularly modern treatment of atrial fibrillation, and also evidence in a diverse population stream. So not only patients with persistent atrial fibrillation, but also paroxysmal atrial fibrillation, octogenarians, young patients, patients with heart failure, obesity, diabetes. And it's formed a pivotal role in shaping our healthcare structure and also shaping the guidelines. Here are some of the important trials, which I'm sure most of you are aware of, but the cryoballoon has been really pivotal in some of the early AF ablation trials. So the idea that we can perform upstream atrial fibrillation ablation in patients with paroxysmal atrial fibrillation, here from Jason Andrade's trial published in the New England Journal of Medicine, where early diagnosis of atrial fibrillation within the last 1 to 2 years, these patients did far better with cryoballoon ablation than they did with antiarrhythmic drugs. And if you look on the right of the screen here, you'll see this huge benefit in terms of AF burden and AF freedom from AF, which is pivotal for patients. We also have the Stop AF First trial, again looking at early recruitment of these paroxysmal atrial fibrillation patients. Within the first sort of six months, these patients have symptoms and are then taken to ablation versus medical therapy. And you see this huge separation in the curves here, where cryoballoon has been pivotal in establishing these guidelines. And then finally, obviously, the Cryo First trial, where we've got, patients within the first 7 to 8 months who are diagnosed with paroxysmal atrial fibrillation enrolled in a one-to-one fashion. And again, you see this fantastic efficacy of the cryoballoon as a first-line therapy for treatment of atrial fibrillation in patients. So it really is the cornerstone of a lot of our treatment, and our guidelines and the evidence over the last, say, 5 to 10 years has come from this excellent technology, which I think still has an important role to play. And we know that, therefore, it is superior to antiarrhythmic drugs for treatment of recurrent atrial arrhythmia in patients with paroxysmal atrial fibrillation, significantly reducing the recurrence of atrial fibrillation, healthcare utilization, hospitalization, and also quality of life. And so we have a tool here that has a very strong evidence base in terms of its utility and how it's used. We also have now further emerging evidence with regard to the use of this in persistent atrial fibrillation. So you'll see on the left here the sham PVI trial, which our group was hugely involved in and recruited, a vast majority of the patients in. And here we recruited, 126 patients who had a placebo procedure or AF ablation, and up to 80% of these patients had persistent atrial fibrillation. And I think the key take home here is actually the mean geometric difference. You see this number on the left, 0.25. That basically suggests that we're getting a 75% burden reduction in atrial fibrillation in these persistent atrial fibrillation patients. So a sort of later downstream cohort of patients, and we can significantly reduce the burden in this quite important and difficult to treat disease. So the cryoballoon has a huge body of evidence, both in paroxysmal and persistent atrial fibrillation. And also to the right here, you see the recent Fire and Ice 2 pilot study, again in persistent atrial fibrillation. And if you look at the graph here in blue, you'll see the significant burden reduction, over 90% burden reduction in atrial fibrillation. So a very powerful tool, which has helped form a lot of our guidelines in terms of how we manage atrial fibrillation. The latest 2024 ESC guidelines suggest that, obviously in patients with symptomatic paroxysmal or persistent atrial fibrillation in whom antiarrhythmic drugs have failed or they have not tolerated antiarrhythmic drugs, AF ablation is the first line tool, and certainly the cryoballoon as a single shot tool has proved to be, the major form for these guidelines. But also in persistent atrial fibrillation, we know that there is still some areas of uncertainty, particularly in persistent atrial fibrillation as a potential first line therapy. In paroxysmal atrial fibrillation, AF ablation as a first-line therapy is now, a class 1 indication. And in persistent atrial fibrillation, we now have several trials, again, with the cryoballoon that are presently recruiting with a view to answering some of these important questions in these more comorbid patients and also in patients with persistent atrial fibrillation itself. We also should remember the safety profile of the cryoballoon. You'll see here on the left an extremely low likelihood of esophageal fistula in these patients. We all know about the phrenic nerve injury risk in these patients, as you see on the right, and about, I would say, around 3 to 4% of patients may incur phrenic nerve injury. But importantly, if you look long-term, there's often no long-term sequelae. It's very unusual that your patient will incur a long-term phrenic nerve injury. So as a tool, it's extremely safe. And when we compare that to other cryo modalities, for example, the Polar X, we have very strong evidence here that the Arctic Front Advance tool is extremely low in terms of its risk for phrenic nerve injury or other significant injury complications, and has an excellent safety profile. So again, as I stated, around a 3% phrenic nerve injury profile, but long-term, very few patients incur long-term phrenic nerve injury. And if we look specifically when we compare cryoablation therapy to, for example, pulse field therapy, we'll see here in the ADVENT trial, for example, that the event rates of complications with the cryoballoon is extremely low, 0%. All of the event rates and complications occur in patients who undergo PFA or RF ablation. So it's an extremely safe, extremely reproducible, extremely durable tool. So in my practice, I like to keep things simple. As Einstein said, a table, a chair, a bowl, a fruit, and a violin. What else do I need to keep me happy? And I like to keep things simple. And the cryoballoon really forms the background in terms of how we treat patients with atrial fibrillation. And I think in terms of workflow and management of waiting lists, it still has an important role to play. It is extremely reproducible. If you look at these graphs here on the right, you'll see that there's a very short learning curve. Within 20 cases, people can become pretty competent operators. And within, 6 months or greater, patients can become expert operators. Fluoroscopy times are extremely low. And certainly in my lab, I would expect to be screening less than 5 minutes for these cases. And I would expect most of my cryo-AF ablation cases to be, less than 60 minutes door to door. And that is extremely reproducible. So you have cases like this where, you put the balloon in. Obviously, I haven't put 4 balloons in this patient. I put them sequentially, but you get very predictable occlusion, you get very predictable freezes, and you get very predictable cases in these patients, which allows you to then work through your waiting list. And in the UK, often without any use of sedation, general anesthetic, just consultant or nurse-led sedation. There's also, often a concern with regard to cryoablation in persistent AF, which we talked about, and I've shown you that there's lots of data supporting it, but also in unusual anatomies. And I would say that with experience, there is no anatomy really that is too challenging for a cryoballoon. The common vein being the most common challenge that people come across is very easy to solve in terms of treatment with a cryoballoon. You can do segmental ablation as shown here in the figures A and C, and segmental ablation results in excellent durable PV isolation and has been shown to be just as good as RF in terms of treatment and PV consistency. And the other thing to talk about here is that as a tool, it is hugely reproducible. So if you look at several centers here across the world with several studies, in paroxysmal atrial fibrillation, we are routinely getting an AF freedom rate of greater than 80% across several centers and several studies. In persistent atrial fibrillation, again, very similar outcomes in terms of AF freedom at 12 months across a range of studies and a range of centers. So we've got a technology here which is extremely reproducible. extremely dependable, and has very clear known outcomes and very clear known metrics. We all know that there are clear temperature guidelines in terms of knowing that you've got a good freeze, so -40 at 60 seconds being the bare minimum, ideally isolation within the first 60 seconds, and also for freezing around 180 seconds or 240 seconds in some cases, but ideally at least 120 seconds greater than your time to isolation. So we have very clear and predictable metrics with this tool, which we don't have with many of the other tools that we use. And we have a tool here that is extremely reproducible and consistent and is very good in terms of delivering for our waiting lists. So I'd like to finish finally by just some quotes from somebody who I think is really the mentor for all of us in electrophysiology. And Mark Josephson said that in the EP lab, we should learn what is known so that we can have the opportunity to discover more. And for me, that take home is do more cryo-AF ablation as a first-line therapy. And where that fails, that gives us the opportunity to then spend time understanding AF that is beyond the pulmonary veins. We should always look to challenge and not routinely accept interpretations in medicine and try and spend as much time writing the literature as we do reading it. And to me, that means that yes, pulse field is an important and very novel tool that we have in our armory. I certainly use it routinely for a lot of general anesthetic cases and redo cases, and particularly where I want to do ablation beyond the pulmonary veins. But we need to understand this tool better. We need to understand the tool, the differences between the different waveforms and the different pulse phases that are available on the market, and how we best use this tool for our general practice. So without further ado, I'll hand back to Professor Osman, and thank you very much.
Thank you very much indeed, Neil, for that excellent talk. So our second speaker is Dr. Verena Tscholl. Dr. Tscholl is a senior electrophysiologist and associate professor at the Charité Hospital in Germany, in Berlin. She's a member of the European Heart Rhythm Association and has extensive experience in ablation. She's very familiar with the CARTO 3D platform and is using both the Affera platforms and the Pulse Select catheter for doing PFA. Verena's talk is on energizing ablation, unlocking the power of pulse field ablation. Over to you, Verena.
Thank you very much for the introduction. Dear ladies and gentlemen, esteemed colleagues, I feel deeply honored to be speaking at this wonderful conference today. And in my presentation, I would like to shed light on the power of the PFA procedure. These are my disclosures. Today, I will talk about why I like to perform PFA procedures, why I prefer a certain PFA system, and I would like to give you a little insight into our approach to patient selection and performing the procedure with the Pulse Select catheter. Well, why do I use PFA? We all have different ideas about a good work-life balance. If you are the type of person who likes to spend long hours in the EP lab, then maybe cryo and RF procedures are a good option. If, on the other hand, you also like to spend time with your family and want to go home earlier, then I would like to recommend the PFA system. You all know the first prospective randomized trial that compared the thermal procedures with PFA, the ADVENT trial. In this trial, the pentospine catheter was used. And in the center in blue, I show you our procedure times for the first 40 patients using the Pulse Select system. We gain over 20 minutes compared to the thermal procedures. If you compare it with the pentospine catheter, we take a few minutes longer to map, but this shortens the overall procedure time with Pulse Select in comparison. And so if you're doing like 3 or 4 procedures per day, you already save 1 hour of your working time. But I know being fast doesn't always mean being better. So pulse field ablation, what we know about it, you know that it's a novel method of cardiac ablation, and electrical fields are used to create microscopic pores in the cardiomyocyte and resulting in cell death. Unlike the traditional thermal radiofrequency and cryoballoon ablation technologies, PFA is cardiomyocyte preferential. And this reduces the risk of collateral damage to the esophagus and phrenic nerve. We know that there are different electroporation zones that are achieved based on how you apply an electric field. The longer the pulse and the greater the voltage, the more likelihood there will be irreversible injury and the possibility also of thermal damage. So the irreversible electroporation zone, as you can see here in the middle, is what we target with PFA. This is where cardiomyocytes die, but the tissue scaffold remains intact. And we know that different cell types have a different sensitivity to electroporation. So cardiac myocytes are especially sensitive to electroporation, and this creates the possibility for us to become like tissue preferential. If you have a look at other tissues like the nerves or smooth muscle cells, you see they have much higher sensitivity to the electroporation. Using conventional technologies like thermal ablation, we have a substantial risk of collateral damage to the esophagus and phrenic nerve. Safety has certainly improved in the last year, as you can see here. We have the number of complications from 2013 to 2017 listed in blue, and in red from 2018 onwards. Nevertheless, serious complications such as permanent phrenic nerve palsy, pulmonary vein stenosis, atrioesophageal fistula continue to be an issue. And atrioesophageal fistula in particular is a rare but usually fatal complication. And as we could show in the PORTER-AF study, atrioesophageal fistula after AF ablation is a rare complication, but it's predominantly happening in RF cases. Cryoballoon cases has a much lower incidence of this complication. And we hope, and the cases and also the data show us that PFA with its non-thermal nature should not create AF fistula. We see this effect in with regard to safety data for procedures with PFA. Here you can see the results of the pivotal study of PySelect, and 300 patients with persistent or paroxysmal atrial fibrillation were included. There were no PV stenosis, there were no phrenic nerve injury, there were no coronary artery spasm, and no atrioesophageal events. You can see here the efficacy of the system. Freedom from atrial arrhythmia recurred after 12 months was like 70% in the paroxysmal group and 62% in the persistent atrial fibrillation group. All patients were closely monitored. They had transtelephonic monitoring weekly. They had symptomatic monitoring. They had 3, 6, and 12 months ECG, and also 6 and 12 months 24-hour Holter monitoring. If we look at the efficacy in terms of atrial arrhythmia burden, we see that we achieve a significant reduction using this PFA system. And this slide, I would like to shed light on the outcome of redo procedures using PFA, cryo, or RF. These are patients who had already PV isolation, and a redo PVI was performed. The PFA in this case was performed with spine catheter. And in the row, you can see that with PFA, the percentage of durably isolated PVs is highest in patients who have had a PFA procedure. And when the PV was reconnected, it was highest 2, but never 4 or 3 PVs like in the thermal ablation procedures. With PySelect, we even have better outcome. These data were presented at the APHRS. Mr. Ania presented data about 25 patients who had a remap after 60 days of the procedure, and 98% of PVs were durably isolated. And this is the highest durability data for any commercial available PFA system since now. Why use this particular PFA system? Well, I believe that the longer you work on a technology and carry out tests and research on it, the more experience and pitfall you can recognize and eliminate. And the first publication of cardiac ablation with PF energy was published back in 2009. Since then, the system has been studied and optimized. The PulseSelect catheter is comprised of 9 electrodes. They are placed circumferentially around the centered catheter shaft. The circular array has a flexible and atraumatic design with like a little forward tilt. That catheter has a central lumen where you can put a guide wire in, and the manipulation of the catheter is possible through a 10 French bidirectionally deflectable sheet. We know that tissue contact is important when performing PVIs. As you can see here, the lesion changes depending on the distance from the PFA catheter. If you have better contact, you will reach a better cardiac lesion. And how do I get contact feedback from the PulseSelect catheter? Electrical stunning can be achieved for hours. We know that from PFA procedure, therefore, signal elimination is not the best surrogate parameter for PV isolation. Similarly, traditional surrogates of effective lesion delivery, like first pass isolation or time to isolation, cannot be used as a criteria for effective energy delivery with PFA. Consequently, it's important that optimal opposition between the catheter and the tissue is achieved prior to deliver the PF energy. Due to its forward tilt, the array might act like a spring and often provides the operator a tactile feedback when he's in contact with tissue. The central electrode number 5, as I showed here, is at the most forward position, while no electrode exists in the most posterior position. And if you can see signals on electrode 5, you can give a little push on the catheter, and signals appear also on the other electrodes. Furthermore, you can integrate the catheter in a 3D map, and then you can see where you are in this 3D map. PulseSelect catheter has a fixed electrode spacing. This allows quite a predictable electrical field. Other catheters designed, like the pentaspline catheter, have varying distance between the splines, and this results in a variable electrical field, let's say. The pentaspline catheter has a 3 times higher plasma-free hemoglobin, as showed here in animal data. And we know that hemolysis is reported in 94% in patient group in the PFA catheter. And since now there are no reports of hemolysis with the PulseSelect catheter. So at the end, in short term, what is our approach with the PulseSelect system? We are doing over 200 cryo-PVI procedures per year in the German Heart Center of the Charité. And until now, we performed 40 PulseSelect procedures. What is our workflow? We do a carto map before and a carto map after the ablation. And our patients have a deep sedation with propofol and fentanyl. The procedure is quite quick and easy. The catheter can be prepared during the transeptal puncture. The catheter central lumen should be flushed with heparinized saline prior to introducing the guide wire. The circular area is then fully submerged in a heparinized saline bath to reduce the risk of air. And the catheter itself is not flushed continuously, so you can start immediately after preparation. The catheter is introduced into the left atrium via a guide wire, and the circular area positioning at the pulmonary vein, you can do it with the 3D map or with fluoroscopy. We place the catheter ostially before we expand the lesions more enterally, and 4 deliveries were applied per placement at the catheter. All deliveries are biphasic bipolar waveforms, and they are automatically gated to the ventricular refractory period. The catheter is rotated continually and placed around each pulmonary vein until you have full electrical isolation. And we use adenosine in every patient to prevent a vagal response. After the procedure, we perform a remap to confirm entrance block. Extrapulmonary procedures have been reported, as you can see here. Isolation of the superior vena cava, the right-sided or left-sided isthmus, or even a box lesion on the posterior wall have been published. The cases show that it's possible to do it, and it's also safe to do it. But more cases are to be done, and further data are needed in this perspective. Our patient selection is limited to patients with paroxysmal and persistent atrial fibrillation without any documented ATAC or atrial flutter. I prefer first do PVIs with the pulse-elect catheter, and for redo procedures, we use the Affera system. And I believe that the following patient group is in particular benefits from PFA. It's the young patients who are athletic, who do sports, older patients with pulmonary diseases, and where we know that phrenic nerve palsy or PV stenosis is fatal for this patient group. Of course, there are also patients who are very well informed and also prefer PFA as a technology. In conclusion, I think PFA is an effective and safe new technology, and different technologies have different physical approaches and vary in their design. I think PulseSelect for PVI, for first PVI, is safe and effective, but still we need a large randomized trial comparing different technologies. We are facing new challenges. We have an increased incidence of atrial fibrillation. We have an increased prevalence of atrial fibrillation. We have a class 1 recommendation for first for PVI for patients with paroxysmal ablation. So I think we need shorter procedure time. But I think if we want to be faster, then use the right technology. Thank you very much for the attention.
Thank you very much indeed for that excellent talk, Verena. So our final speaker is Dr. Ioanna Koniari. Dr. Koniari works at the University Hospital Patras in Greece. She's trained at the Royal Brompton in Birmingham, in Manchester, and also at the Liverpool Heart Centre, where she remains an honorary associate. She's also worked as a consultant electrophysiologist in Blackpool, before returning back to Greece. She's also a fellow of the European Society of Cardiology and the European Heart Rhythm Association. Dr. Koniari's talk is entitled Synergy in Practice, Enhancing Outcomes with Cryoballoon and Pulse Field Ablation. All yours, Ioanna.
Thank you very much for your kind words and your kind introduction. I am trying to talk about the synergy in practice and how we can enhance outcome with both cryoballoon and pulse field ablations. It has been demonstrated with before of studies, as the previous, as Neil mentioned as well, that the cryoballoon has a high efficacy in case of paroxysmal atrial fibrillation that is more than 80%. Similarly, there is strong evidence that in case of persistent atrial fibrillation, that freedom from atrial fibrillation can be succeeded for 54 up to 82% of patients in different centers. Regarding the PFA, we have the Pulse AF pivotal trial, as Verena mentioned before, that it was a trial non-randomized trial, prospective, global, that enroll patients, 300 patients with other paroxysmal or persistent atrial fibrillation, and demonstrated that the freedom from atrial arrhythmia recurrence in case of paroxysmal was 69.5% after the 90-day blinding period, and in case of persistent, 62.3%. It is notable that in the same trial, the clinical success, meaning the freedom from any symptomatic recurrence of other of atrial arrhythmias, almost reached 80%, both in paroxysmal as in persistent atrial fibrillation cohort. The key of a successful workflow is how we can combine the existing and the new technology. The existing, the very well-established cryo balloon, and the new technology with the pulse-elect PFA catheter, so as to achieve best outcomes regarding in our patients, regarding the safety and of course the effectiveness. At the end of the day, it's these two technologies, the thermal cryoballoon and the non-thermal pulse-elect, can be combined harmoniously in our daily clinical practice and can be individualized to meet different patient needs. Before we perform a procedure, we may think different aspects, and we may take into consideration different parameters. The first is the nature of the arrhythmia, if it's paroxysmal or persistent AF. The second is the availability in our center of general anesthesia, or if we have developed already deep sedation protocols. Third, the duration of the arrhythmias. This is reflected by the LA diameter. As we all know, that in the long-standing persistent AF, the electrical remodeling is followed by anatomical remodeling and an increased LA diameter. What we need to do, if we are going to do only a pulmonary vein isolation, or if in case of long-standing persistent atrial fibrillation, if we need to go for extra lesions such as posterior wall isolation. Another aspect is if it's the first ablation or it's a redo ablation procedure. A very significant parameter is the cost effectiveness, and if we have a mapping system availability, and what is the cost of this mapping system to be incorporated in our workflow. And of course, at the end, we need to ask the patient and about the patient preference about which technology would like to undergo the procedure. There are some factors that we would say that favoring its technology. These factors might be definite or might be potential due to lack of randomized trials in pulse field ablation. As Neil mentioned before, there are three randomized studies, the STOP AF trial, the Cryo-AF, and the LEAF, that have established the superiority of cryoballoon over the antiarrhythmic therapy in case of paroxysmal atrial fibrillation, while the Progress AF trial has demonstrated that a cryoballoon, a Medtronic cryoballoon, is disease modifying and lowers the rate of development from paroxysmal to persistent atrial fibrillation. There is very well evidence, as we have all mentioned, that the cryoballoon is a reasonable and efficacy and effective technique in case of both paroxysmal and persistent atrial fibrillation. On the same time, there is a very well-documented safety and reproducibility in variant anatomy, such that we can face in the daily practice in the lab, such in left common pulmonary veins or in middle right pulmonary veins. And of course, cryoballoon has been tested in a diverse population such as heart failure patients, obese patients, diabetic, even octogenarians and females. And we should not forget that there is already the East High apnea trial that is recruiting patients with a high comorbidity burden so as to address the effectiveness of cryoballoon in these cases. On the other side, the pulse field ablation with the pulse select catheter has been based on the studies that I mentioned before. It has been recommended both in paroxysmal and in persistent atrial fibrillation. In cases of, given the anatomical shape of the catheter and the shaft and the anatomical shape and the circular array catheter, we can perform circumferential lesions and we can achieve antral, ostial first and antral overlapping lesions so as to have a successful pulmonary vein isolation that is ideal in long-standing persistent atrial fibrillation or when we have greater LA volume. Also, given the fact that PFA is pulse field ablation is preferential tissue ablation to cardiac myocytes. It has its indication. It may have its indication in the patients with high BMI or with comorbidities, of course, when DA is available in order to facilitate things with TOE. And of course, given the reduced collateral tissue damage, we may adopt it in our daily practice in high risk or frail patients, as Verena mentioned that we don't have any pulmonary vein stenosis or non-phrenic nerve injury or esophageal fistula. And of course, it can be used and it can be adopted in cases that we need to perform an extensive ablation, such as box lesions and posterior wall in long-standing persistent atrial fibrillation. And it can be safe and effective in reduced cases, of course, with mapping. So how we can combine the safety and efficacy of these technologies in both paroxysmal and persistent AF patients? One ideal workflow in the lab would be to have a GA list in the morning, or in centers in Greece we haven't developed yet any deep sedation like the UK protocol, so we still need the GA cover in order to perform the PFA. So in the morning we can put 2 first-time persistent AF cases with the pulse select PFA catheter, while in the afternoon we can switch to a sedation list with 2 or 3 cryoballoon, other paroxysmal or persistent pulmonary vein isolations. Here we can see the circular catheter, the circular pulse select catheter that is in left upper pulmonary vein. And the fact is that, as Verena mentioned, that we can rotate the catheter circumferentially so as to cover a wide area and to perform overlapping lesions. And from ostial, giving 4 ostial applications and continuing with the antral application. It is important that in case of PFA, to perform other NLA venogram with the transeptal sheath or other selective venograms with the 10 French sheath of the pulse select catheter, so as to know the vein anatomy and, of course, the caliber of the vein. In this slide, we can see in our workflow the visualization of the pulse select catheter that can be incorporated in different mapping systems. Here is a within-site mapping system that we can track the lesions that have been performed with the pulse select catheter, as we can see on the right figure. And it's evident also the wide circumferential PVI and the isolation of the pulmonary veins. On the other hand, the cryoballoon is a safe, reproducible, effective technique that we all know and we all perform with the short learning curve, as Dee mentioned, that we can see here that we don't need, we can perform, of course, LA angiogram, or we can perform venograms during obstruction with the balloon, and we can see the excellent occlusion in our veins. However, even with the cryo, we may have sometimes some surprises can occur, as in this case that I did recently. And actually, it was left persistent SVC with no access to right phrenic nerve that we continue, of course, to finish the procedure and to do the right-sided veins with the cooperation of the patients and targeting in low temperatures and during dynamic respiration of the patient, and of course during fluoroscopy, fluoroscopical monitoring of the diaphragmatic movement. And at the end, we may not forget that in case of long-standing persistent AF or coexistent flutter, we may have surprises and they may unmask, in some cases, 6-time syndrome, as in this patient that we ended up to implant a permanent pacemaker. The benefits of the two technologies, the benefits of cryoballoon and of the PFA catheter. We know that, as previously mentioned, that the cryoballoon significantly lowers its disease modifying, as significantly lowers the rate of AF progression and increasing the quality of life and reducing the hospitalization rates. On the other side, it's a well-documented, safe and reproducible technique that it has been tested in a variety of pulmonary vein anatomy in a diverse population groups and a high comorbidity burden, as it is tested in the ISTAFNet High trial. There is a short learning curve after 30 procedures, and one can perform a safe and effective pulmonary PVI, and with a shorter duration of fluoroscopy time, increasing the lab efficiency. On the other side, the PulseSelect, the PFA catheter, is a preferential tissue. We can perform a preferential tissue ablation, as it reduces the collateral damage. The shape of the anatomic shape of the PulseSelect catheter with the stable electrode site and distance can ensure that we will deliver stable reproducible lesions and continuous lesions in even trabeculated structures, while it's a rapid ablation with a fast deliveries, and as we mentioned before, we can achieve circumferential and wide pulmonary vein isolation. And especially the anatomical shape of the circular array that leaves a horseshoe shaped lesion is easily can be easily used with minimal catheter placements, and we can achieve good results. Of course, it can be used for extrapulmonary structures, as it is the pulmonary, as it is the posterior wall isolation that we can incorporate in our strategy in case of long-standing persistent atrial fibrillation, or it has been used safely also in the isolation of SVC. It has increased safety, and we can offer a rapid ablation in redo cases, as this can be incorporated in our existing mapping system of the cartridge and site. And of course, it's a safe and efficient technique with evidence of lesion durability, as the Verena study demonstrated recently. In conclusions, both cryoballoon and PulseSelect can be combined harmoniously in daily clinical practice, enhancing safety and clinical outcomes. The future of the PFA is to use it in redo cases, of course, with our mapping system due to preferential tissue ablation and reduced collateral damage. Of course, further research needs to be conducted so as to assess the PFA use beyond the pulmonary veins in other anterior or posterior LA wall in the mitral isthmus, as well as the long-term lesion durability. Thank you very much for the attention.
Thank you. Thank you very much indeed, Ioanna, for that lovely talk. Okay, I'm going to open up the panel discussion now. We do have limited time. I think we have around about 7 minutes that we're allowed or thereabouts. So I'm going to open up the panel discussion. And if I can start with you, Neil, and ask you about your cryoballoon experience and the throughput through the cath lab. I alluded to at the start that our waiting lists were horrendous, and I think they are everywhere, particularly in the UK, and the cryoballoon made a huge impact for us. Could you just talk us through some of the throughput issues maybe that you've had at your hospital? I think you might be on mute. Neil.
Similar to you. So we've had a boom in AF ablation. The volume of patients coming in, the indications, etc., are growing. And the other thing I think is with the safety profile of the cryoballoon, you're far more confident to take on more patients, high BMIs or more comorbidities, because once you've done your transeptal, you've basically got an airbag in the left atrium. You're very unlikely to do any harm. And for us, the way to get that waiting list down was to have a consistent, reproducible procedure. Every case is the same. You can work on lab efficiency that way. And then you can work by streamlining your lab that everybody knows to get the balloon ready at the same time as you get the sheath, so that as soon as you're transeptal, you have a balloon ready that's ready to go across into the septum, no waiting around, all those kind of small efficiency progress strategies. You can easily deliver somewhere between 4 and 6 cases per day in your lab. And in our case, it's fantastic for beds because none of these patients stay in overnight. They all go home. The other thing that is very helpful is that we also work as a tertiary center with satellite centers. And the cryoballoon gives you the confidence to open satellite centers doing cryo-AF in some of your district general hospitals, for instance, without a cardiothoracic surgeon on site, because of the day case applicability of the procedure and how reproducible it is. It's very easy to train even non-EP cath lab staff to deliver this procedure consistently.
Great, no, fantastic. And we've had exactly the same experience here in Coventry as well. And as you said, it's allowed us also to develop satellite hub and spoke sites, as well as doing day case ablation and getting more volume through. So that's been critical. Can I just ask you very quickly, do you do direct transeptal puncture at your center?
Yeah, absolutely. So I use FlexCath, but I've also used the new contour sheath. I take an 89 BRK, and I directly take a SafeStep needle. And even with the FlexCath, it's very easy to cross straight away. So there's no exchange required, which again saves time. But also, I think less exchange is safer. And the ability to have a wire through a SafeSept, or there is also the new needle from Medtronic with an over-the-wire equipment to it. I think that really helps in terms of your efficiency, but also your safety without exchanges, etc.
Yeah, no, I agree with that. We do something similar. We always go direct, both with the old FlexCath and the contour. And we always ensure that in our center, we actually put a wire, usually an Amplatzer super stiff, up into the left upper or pulmonary vein to allow us to get the sheath across directly. And that, it does save a little bit of time. And it's all about marginal gains. If we can improve or shave a little bit of time off in each of the steps, then actually your small margins will make a huge difference, I think, at the end. Verena, if I can ask you a question around the choice. So we've had several people ask about factors choosing between cryoballoon and PFA. You've nicely shown the data for that. And in your center, and Ioanna has also indicated some of the factors she looks at. But what do you kind of look at? How do you decide when you see a patient, yes, this patient should have a PFA, or maybe this patient should have a cryoballoon?
Yes, this is a good question, but I think, yeah, I have to admit that it's also billing reasons how we choose our patients for the systems, because normally I think I completely agree that if you have a patient with paroxysmal atrial fibrillation, it is safe and you have a good efficacy to do a cryoballoon ablation. And that's what we do quite a lot more cryoballoon ablation in these patients. But I think if you're looking at some patients, like patient with pulmonary disease, even obese patients, where really you are worrying about this even rare complication, then we definitely use PFA.
Okay, and does sedation or GA play a part? Obviously, we do our cryo balloons with conscious sedation. Here in the UK, cardiologists are not allowed to give propofol, which is incredibly frustrating. But you know, would love to give it. I know in Germany, for example, cardiologists do give it, and specialist nurses are able to give it. So, and we know that doing PFA without having either full intubation or at least deep sedation with propofol or the like plays a part. Is that something that comes into play for you at all in Germany?
Yes, we don't use GA. I did my first Afera cases with GA because it was recommended also from Medtronic to do it. And surely there's a difference because with pulse field ablation, you have also this cough sometimes, and also the patients are moving. But with the pulse electric catheter, you have so fast points of this pulse field energy that you don't really have a problem with anesthesia. So I would even try to do it. I didn't do it until now with fentanyl and dormicum, but I think because there's so quick application, so maybe you can do it also easily only with fentanyl and dormicum, and you don't use propofol.
So just clarify for us what the last agent was. Fentanyl we certainly use. We tend to use midazolam, I think most of us in the UK. What is that last agent you mentioned? Sorry. Is that midazolam? Is that a benzodiazepine?
It's a opioid, fentanyl. It's an opioid, and it's benzodiazepine. Yeah.
Okay. So we tried, and I'd be keen to hear what Neil and Ioanna think. But we did try doing a case with sort of conscious sedation, but a little bit deeper with an anaesthetist present. But I don't think the patient tolerated it. We also did use a little bit of ketamine as well. But the anaesthetist had to give remifentanil and propofol to get the patient a little bit deeper. Neil, Ioanna, do you have any experience with going a little bit deeper when you're using PFA? Neil, if I start with you.
So very similar to you. I mean, you don't necessarily have to have the patient fully paralyzed and intubated. We've done quite a bit with propofol and remifentanil. But similar experiences to you in terms of trying to do it with less has been problematic when we haven't solved that yet. And I think that's the big challenge in the UK to, get this going as a sort of similar manner to cryo-AF ablation. It certainly is fast, certainly very safe and effective. It's just trying to work out how do we do that without the general anesthetic.
Yeah, great. And Ioanna, any further comments to add to that?
In my center in Greece now, I have tried, I prefer the anesthetic support because it's like the UK, we cannot give propofol, or we are not trained to perform procedures under deep sedation. But of course, I have under anesthetic support, we try deep sedation with the anesthetist, and we have apnea. So the anesthetist came over and put a laryngeal mask. And at the end, the patient went fine. But of course, if you are an operator and you need to have some more support from other colleagues or ODPs, like in the UK, or well-trained nurses to deep sedation in order to perform this in daily clinical practice.
Okay, thank you very much indeed. I'm just being told in my ear that sadly we've run out of time. There are some excellent other questions that have been asked. I'd like to thank all of our speakers today, to Neil, to Verena, and to Ioanna, for talking, giving us excellent talks today. I'd like to thank the audience for joining us. And just to remind you again, this symposium today was supported by Medtronic, and I hope you enjoy the rest of the day and the rest of this Rio as well. Thank you and goodbye.
Okay.